tissue, following by maxillary surgery. Dr. Yixuan, please.
Good morning. I'm going to present my study about the effect of clockwise and counterclockwise rotation on facial tissue, following by maxillary surgery. Start from the introductions. Actually, there are many studies about the soft tissue changes after true jaw orthodontic surgery. Since before 3D technology have been introduced, and in 2D evaluations, it's mostly in sagittal and vertical dimensions. As far as we have 3D CT and 3D facial scans now, studies on frontal changes of soft tissue reveal that nose get broadened, the dorsum of nose and the cheek advanced after maxillary advancement, and protrusion of lower lips relieved by mandibular setback. However, most common Asian facial characteristics are pre-existed dental alveolar protrusion with a flat facial profile. So a pure translational maxillary advancement and mandibular setback procedures may aggregate this pre-existing dental alveolar protrusion. So most of the patients undergoing with OGS will receive rotation of the maxillary mandibular complex, MMC, in clockwise or counterclockwise direction to control and enhance the facial aesthetics and function. However, there are very few reports addressing volumetric changes of the facial soft tissue, including paranasal and perioral regions after pure MMC clockwise or counterclockwise rotation, and mandibular setback with little maxillary advancement. So the purpose of my study was to assess the correlation between skeletal tissue rotational effect and soft tissue facial changes three-dimensionally after clockwise and counterclockwise by maxillary orthodontic surgery. The material and methods of my study. This is a retrospective cohort study, and we enrolled consecutive subjects who had complete surgical orthodontic treatment at the Department of Craniofacial Orthodontics in Chang'an Memorial Hospital, Taipei, and Taiwan branches between 2014 and 2019. The sample size calculation is for a 5% significance level with a power of 80% and an effect size of 0.8. And this is performed with the parameters reported by a further 3D volumetric study by Van Loon. And the study protocol was reviewed and approved by the hospital's IRB. The inclusion criteria of the study is first, non-growing patients aged elder than 18 years old with skeletal class 3 malocclusion, which is defined by A and B angle less than 0 degree. Patients received bimaxillary orthodontic surgery consist of the full one osteotomy and bilateral sagittal split osteotomy mandibular setback. Patients received complete surgical orthodontic treatment. And we exclude the patients from the following: patients with syndromic disease or craniofacial anomalies, patients with cleft lip and palate, previous history of facial trauma or craniofacial operations, patients received genioplasty during OGS, and incomplete data. We acquired image acquisition and analysis. We would acquire combing CT data and 3D photos from 3D MD in two different timing. T1 is preoperatively and T2 is finished during after the complete orthodontic treatment, and which is more than 9 months of post-operatively. And the software we use to measure the volumetric changes are 3D Medic software and OGA version 2.0 and maxillary software. The 3D Medic software we're using to measure with the hard tissue movement with OGA version 2.0 and the volumetric changes. As for maxillary software, we'll measure with linear and angular measurements. Our first introduced OGA version 2.0. This is OGA is an abbreviation for orthodontic analyzer version 2.0. It is a module which is implemented in 3D software called 3D Medics, and it is developed by the 3D Lab Radboud UMC in the Netherlands. 3D Medics then is a standalone software tool based on the C++ Toothkill. And this OGA is able to assess the accuracy of maxillary surgery. It is first introduced in 2016. With OGA, it is easily, after we position the skeleton in a natural head, in a standard head position, then it is an auto, semi-auto program that we can only point out a few landmarks, then it could automatically do the maxillary and mandibular superimposition as the figure shown. And then it will automatically give us 6 degrees of the movement of the skeletal, including maxilla, mandible. And in OGA version 2.0, they also is able to measure the genioplasty movement. But we are excluding the genioplasty patients in this group, so we're not going to measure that. So the result will show in figures and in directions and numbers. This is what we do for the skeletal movement. And so first, we will do the superimposition with the voxel-based registration. Then after voxel-based registrations, superimposition will measure the skeletal, maxillary, and mandibular movement. So we got the translation, rotation of the maxilla and mandible in 6 degrees. Then we will proceed with the superimposition of 3D photos, 3D MD onto the combing CT. We will match a point, a region, and then do the surface-based registration, then do the superimposition. This is the definition of the landmark of our analysis. First is the skeletal. We will mark the nasal, sella, porian, orbitally, frontal zygomatic point, A point, B point, upper incisor midpoint, upper first molar, bilateral upper first molar point, Pogonian, Manton, and Gonian. Then we will proceed to the soft tissue point landmarks, including soft tissue nasal, alar, subnasally, stomian, sublabially, Chelian, and soft tissue menton. Then we will use the soft tissue, the landmarks we mentioned above to construct a reference horizontal, sagittal, and coronal plane according to Swennen, Dr. Swennen in 2006. Then we will also define 10 planes and 1 maxillary occlusal plane. And this maxillary occlusal plane is a dental occlusal plane. So the landmark is will pass through upper incisor and upper first molars. So these are the 10 planes and 6 facial regions we set it up. These 10 planes are as follows. 1 is left nasal plane, 2 is right nasal plane, 3 is frontal zygomatic right plane, Chelian right plane, Chelian left plane, frontal zygomatic left plane. And the horizontal plane, including frontal horizontal plane, horizontal subnasally plane, horizontal stomian plane, and horizontal sublabially plane. And these planes, we will set up 6 facial regions, which we are interested in, including nasal regions, right and left cheek regions, the upper lip regions, the lower lip regions, and the chin regions. And to close the 3D-MD volume, to calculate the volume of this region, we use the reference coronal plane as a backplane to calculate the region's volume. Then after we calculate and all these measurements, we will do the grouping with the surgical achieved maxillary occlusal plane changes. We use the threshold as maxillary occlusal plane changes more than 2 degrees as clockwise and non-clockwise rotations. So the clockwise group is defined as a surgically achieved occlusal plane change greater than more than 2.5 degrees. And in a counterclockwise rotation, we will categorize those less than minus 2.5 degrees. And in the statistics, due to there's a covariant of age and sex, we will first use inverse probability of treatment weighting to adjust the covariant. And then we will do the intergroup differences, including student t-test and chi-square test. The mean difference is significant, is set at 0.05 level. And we also check the intra-rater reliability, which the ICC is high, more than 0.98. So we'll see the results. First is the patient demographics and clinical information. We got 2 groups. First is a clockwise group, and the second is counterclockwise group. There's 20 patients in the clockwise group and 17 patients in the counterclockwise groups. There's 3 males in the clockwise groups and 4 in the counterclockwise groups. And we do the statistics, and we found there's no significance in the age, gender distribution, SNA, SNB, and ANB. Then we will see the 3D skeletal movement between 2 groups. In these 2 groups, we will find that the mean maxillary occlusal plane rotation in clockwise group is 5.91 degree, and in counterclockwise rotation is minus 5.2 degrees. And we can see from this table that the only significance between two groups of the skeletal movement are maxillary occlusal plane changes and maxillary pitch changes, mandibular pitch changes. And as for the maxillary AP and down, up, right and left, mandibular AP, down, up, and right and left translational movement are non-significant, all non-significance between two groups. And we also found the intergonial width are a significant difference between two groups. In the clockwise group, we can see that significant decrease of the intergonial width. And there are little maxillary advancements in both groups. Then we'll go see the volumetric changes of these 6 facial regions of interest. From these 6 facial regions volumetric changes, we found that only the chin volume is significant decrease in the clockwise group than the counterclockwise group. We also calculate the mean movement of these 6 facial regions. The mean movement was calculated as the volumetric changes divided by the preoperative surface in each region, and it can be defined as the displacement of the center of gravity of each region. However, although there's no significance or non-significance between two groups, although we found that there are volumetric significant decrease in the clockwise rotation group, we didn't see a severe significant chin regions significant movement than counterclockwise group. We also measure some linear soft tissue measurements, including soft tissue nascent to mentum and soft tissue nascent to subnasally and interalar width. And from this table, we noticed that there are no significance between two groups in all these soft tissue linear measurements. Which means that clockwise and or counterclockwise rotation do not change the soft tissue anterior vertical facial height or interalar width significantly. So this is the example of the postoperative 3D volumetric changes in oblique view between two groups. The left side is a clockwise group and right side is a counterclockwise group. So we can see the direct view of the counterclockwise with a significant decrease of intergonial width, significant decrease of chin volume, and slender lower face. Then we'll go to the discussion. This study evaluated how facial soft tissue and skeletal tissue after maxillary surgery differed according to the changes of maxillary occlusal plane angle. The postoperative soft tissue changes between two groups only presented significant differences over the chin volume of the 6 facial region and the intergonial width. The strength of this study is this is an age match and sex match study. We adjust the covariant of age and sex to stabilize the variance estimate, so the treatment effect and their variance can be estimated directly using the conventional statistics. And this IPTW's method can also preserve the original sample size while creating the pseudo data set. And this study presents a pure clockwise and counterclockwise effect. Only maxillary occlusal plane change, maxillary pitch, and mandibular pitch changes are a significant difference between two groups. So there is a homogeneous skeletal movement except pitch rotation between two groups. And in two groups, they are all with little maxillary advancements. The mean movement of the maxillary advancements in clockwise group is 0.2 millimeter, and in counterclockwise rotation is 0.98 millimeters. And we also use 3D comprehensive hard and soft tissue evaluation. The first one is OGA version 2.0. We use this module to reduce multiple landmarks identification and increase accuracy. And from the previous study that the accuracy of the OGA, their linear measurement accuracy is less than 20, the linear error is less than 0.23 millimeter, and the angular error is less than 0.67 degree. And the 3D stereo photogrammetric regional measurement can also provide quantitative evaluation of the post-surgical soft tissue changes. With 3D camera system, the accuracy is up to 0.2 millimeters, so it will provide us precise volumetric changes. And it is a clear and intuitive view of the post-op soft tissue responses. We can also use direct anthropometry of the landmark to reduce the identification of error and repetitive errors. And we also decrease the selection bias and unreliable outcomes by avoiding inaccurate lasso or brush tool method, which encircle target areas manually at different time points. As for the results in the mid-facial region, including nasal and cheek region, in our study, the postoperative mid-facial region did not show significant changes over volume and mean movement. So the counterclockwise or clockwise MMC movement do not affect the postoperative mid-facial region significantly. And it is also supported by previous studies. Cho in 2021 also supported that clockwise reposition with little advancement of the maxilla and mandibular septum might induce only minimal changes in the paranasal area. And this study is used by 3D soft tissue volumetric measurement and 2D hard tissue cephalometric measurement. And from Dr. Lowe's group reported, they also mentioned that maxillary advancement had a larger effect than maxillary rotational movement in a normal class 3 patient. And in cleft class 3 patients, only surgical maxillary advancement had a significant impact over the cheek soft tissue changes. And all these differences in mid-facial volumetric changes could be diverse due to the diverse direction and amount of the maxillary surgery and different methods of volumetric evaluation. And in the interocular width, in our study, the post-op interocular width only increased 1.4 millimeter and 1.22 millimeter in clockwise and counterclockwise group respectively. And there's no significance between groups. And from the previous studies also shows that only maxillary posterior superior impaction and mandibular rotation standpoint might increase the alar width. And in the recent systematic review regarding 3D nasal labial changes after the 4-1 osteotomy only, that concluded that only intra-alar width widening are more relevant to maxillary impaction than advancement and not related to maxillary inferior position and inconclusive to rotational pitch. And as for the upper lip region in our study, there's no significance between two groups over post-volumetric changes. From the previous study that reported that upper lip decrease about 12% due to the reduction of upper facial height after the 4-1 maxillary advancement and mandibular setback. And a previous 3D volumetric soft tissue study also supported that upper lip volume increased by 2.23 cubic centimeter according to maxillary advancement, about 3 millimeters. And in 2021, Cho also mentioned that clockwise reposition with little advancement of maxilla induced minimal changes in the upper lip area. And for the lower lip regions, there are no significant, and chin, lower lip and chin regions, there are no significant difference between two groups in lower lip region. And there was significant reduced volumetric changes in the chin region in the clockwise group than in the counterclockwise group. Because in this study, patients with genioplasty were excluded. So this postoperative chin changes were mainly effect of the BSSO and MMC rotation and is not interfered by genioplasty. And from the study recently also supported that a clockwise reposition with little advancement of maxilla and mandibular setback would induce volumetric change mainly in lower lip and chin area. Around 13%. And in the intergonial width in our study, we also showed that intergonial width was significant decrease in the clockwise group compared to the counterclockwise group. In previous study in 2017, they also find the similar result, while clockwise rotation will reduce the intergonial width and it will present a more frontal slender look over lower face after bimaxillary surgery. And this is the arc overlapping of the tracing lower border of the mandibular shows effect they showed. The limitation of this study was the factor contributing the soft tissue changes such as BMI and the laxity of soft tissue were not fully evaluated in the study. In addition, postoperative soft tissue thickness of lip and chin might react diversely due to different vertical facial patterns. Nevertheless, the finding of this study helped clinicians to picture the post-op facial soft tissue changes of clockwise and counterclockwise rotation in the bimaxillary surgery easily. Furthermore, improve the predictability of post-surgical soft tissue aesthetics. The conclusion of my study is the clockwise rotation of MMC in skeletal class 3 patients significantly reduced chin volume, and non-significant difference is in nasal, cheek, upper lip, and lower lip post-op volumetric changes than counterclockwise rotations. Patients with skeletal class 3 occlusion, decreased chin volume, and intergonial width produce a more slender lower face after bimaxillary clockwise rotational surgery. This is the end of my study, and I would also like to share you a good news that the MOU between our CGU and our Craniofacial Center with the Red UMC and maxillofacial department and 3D labs have all been received and approved. And today is the summer solstice, so hope everyone enjoyed the longest day in the year. Thank you. This is my presentation.
Thank you, Dr. Chen. Is there any question or comments from the audience? Dr. Chen, may I ask you one question? That is there any difference between the two groups, the counterclockwise and clockwise? Is there any difference in the movement of A point or B point?
Because we use the OGA, so I didn't measure the movement of the A point and B point. Because we will try to see the whole measurement as of mean movement from the whole maxilla and mandible, and we want to reduce the landmarks measurements, the error of the landmark measurements. So I didn't use the A point, measure the A point or B point movement in the study.
So are all these patients class 3 or some of them belongs to different classes?
All of these patients belongs to class 3 patients. Okay. With A and B angle less than 0 degree.
Thank you. Because in if you include different group of patients, there could result in a significant difference in the cheek or the bilateral paranasal area.
Yes, thank you, Dr. Lee. Because this is a retrospective study, so we include consecutive class 3 patients from 2014 to 2019. And actually, we exclude a lot of patients. If the patients have a genioplasty, then we are excluded. And if the patients are the maxillary occlusal plane changes are not above 2.5 degree or less than 2.5 degree, we also excluded. So we actually made effort over including these homogeneous skeletal movement of these patients, class 3 patients. And we hope to present a more pure clockwise and counterclockwise rotational effect.
Yes, thank you. Can we invite Dr. Zhou Bangyu? Could you give us some comments, because you had some study about the paranasal area soft tissue movement?
Yes, thank you, Dr. Chen's very good presentation, and congratulations. This is a very well organized study. First of all, I have one question, is that even though all the patients are belonging to the class 3 malocclusion, so what is the decision make your group to decide to make a 2.5 more or less than 2.5 rotation in such kind of group? And what is your final goal want to achieve to divide it into the two groups? for probably a simple classification of a class 3 malocclusion. Because I think in this paper, another very important issue is, I think all the orthodontic doctors should let all the readers to know after the surgery, what is the post-op, the orthodontic treatment you want to perform or to reach to your final goal. Yes, this is my question. Thank you.
Thank you, Dr. Cho. And first, the grouping of these two groups for clockwise and counterclockwise group. From the research from the previous study, we only found more clear threshold cut point over the maxillary occlusal plane, which is more than 2 degrees, and it is quoted by Prophet, which is a very famous orthodontic doctor. And so we try to use 2 degrees, but we think that maybe 2 degrees is may not show us more significant changes. So we added the effect over clockwise group to see the surgical achieved occlusal plane changes more than 2.5 degrees. And in the counterclockwise group, we categorize them less than minus 2.5 degrees. This is how we define these two groups according to the maxillary occlusal plane. And as far as we do the research of the maxillary pitch, we didn't see there's any literatures showing that the clear cut point over maxillary pitch. So we didn't use this maxillary pitch as a grouping definitions, for clockwise and counterclockwise group. And
okay. Thank you.
Thank you.
Professor Lo, could you give us some comments?
Thank you, Carol, for the presentation. And I think your presentation further provide information about the soft tissue change. As a surgeon who are dealing with the facial skeletal morphology, I think we all need this kind of information. For example, when we do the facial bone impaction or vertical shortening, rotation, counterclockwise or clockwise, we certainly should understand, in addition to the skeletal change, what will be the soft tissue change. For example, we for the skeletal class 3 patient, we very often design a clockwise rotation. And certainly this will increase the chin volume or even creating so-called double chin appearance. So when I design this, I always add an advancement or lengthening genioplasty in order to reduce the soft tissue accumulation under the chin. So this kind of information is quite important when we, and also important information when we design the skeletal positional change. So thank you, Carol. I think this is an important study.
Thank you, Dr. Lo.
Thank you.
This is Dr. Huang.
Yes, please.
This is Dr. Huang. Could I ask one question?
Yes.
According to your PowerPoint here, you have a clockwise and counterclockwise rotation. And the first question will be, where is your rotation center during the surgery?
Thank you, Dr. Huang. According to the grouping, we are using the maxillary occlusal plane changes. So there's more rotational pivotal point. And as for in the OGA, the skeletal, the maxillary pitch, we're using upper incisor as a pivotal point for the maxillary pitch result. And the mandibular pitch is using lower incisor point as a pivoting point over the mandibular pitch. So the results are all shown for maxilla and mandible. The pivoting point is over upper incisor midpoint and lower incisor midpoint.
Yeah, be careful because you should know where is a rotation center for your study. My second question is, you mentioned about your maxillary surgery have minimal surgical movement, but your occlusal plane, your maxillary occlusal plane is minus and positive around 5 degrees. That's a lot of change. And so I don't know, is that due to the surgical movement or due to orthodontic movement? Because your surgical movement is minimal for the maxilla. Occlusal plane shouldn't change that much, almost 10 degrees different between these two groups.
Yes, Dr. Wang, this is a very good point. In the very beginning, actually, we want to use maxillary pitch as the grouping, but from the literature, there is no definition for the clockwise pitch and counterclockwise pitch. So we choose maxillary occlusal plane, which is a dental, which could include a dental effect as a grouping. So we also presented this results, and from this result, we can show, although there's larger changes over dental effect on the maxillary occlusal plane changes and maxillary pitch changes are both significant different in these two groups. So we're basically, it means that these two groups in pitch rotation, pitch movement is different, yes.
Yeah, overall, it's a very nice start for soft tissue analysis. Congratulations. Thanks.
Thank you, Dr. Huang.
And we have a question from Professor Lo, Dr. Lo.
Yes, Carol, I think from your presentation, you mentioned that we have a collaborative study between our center and the center in Poland. Are there any ongoing study, or do you see any possibility of the future imaging related study that we can do between the two centers?
I think the orthodontic surgery study they're using right now is basically using by these two softwares. And then because their surgical simulation is mainly using by IPS, so they're now continues their 3D medics to analyze the IPS simulations afterwards. So it will they're like first using IPS for surgical simulation, then they will directly move to 3D, and then they can output the surgical movement from IPS, then analyze in 3D medics. This is what they are doing right now. And I think although the patient's characteristics of Caucasians and Asians are very different, so the movement is also very different, but their center also performed the 4-1 and BSSO osteotomy in the two-jaw orthodontic surgery. Yes.
Thank you, Dr. Chen. And can we invite Professor Yurei Chen to give us some comments?
Thank you, Dr. Chen. Is this paper being published or submitted to any journal?
I'm now submitting these papers. Yes.
Thank you.
So it's not yet accepted.
Thank you. I think that in collaboration with Netherlands, Holland is very important because what they analysis is a Western faces, and in our area it's different. So maybe some of us that can use the IPS for some patients so that we can collaborate each other using your software and see what kind of result. But for the surgical planning, I think we more consider about Asian faces. So the treatment planning itself, I think there's some difference, which maybe that can have some kind of study between the two centers. So this is maybe that we can collaborate with each other in the future. Thank you.
Thank you.
And is there further questions or comments? Dr. Zhang, Frank Zhang.
Yes.
Do you have some comments or questions?
Yes, I have one question for Carol, and thank you for your presentation. Then we know you use different software for simulation, and do you show the soft tissue prediction for the patient? And if you show to the patient, how is the difference between clockwise, counterclockwise, the real surgical result and your soft tissue prediction? And second question is normally we do sample size calculation for prospective study, especially for prospective randomized clinical trial. Normally, we do not do sample size calculation for retrospective. And can you explain why you do the sample size calculation? Thank you.
Yes, thank you for your comment. And first, I use two surgical simulation software. First is IPS and second is Dolphin. I show to patients the soft tissue simulation, but I often tell them that it's not. It is also a simulation one, so it might not be very real. And I think the soft tissue simulation is, according to the literature, it's around 0.3 or 0.4 millimeters error over, especially over lower lip, and so, and especially over the vertical dimension. So I think it should be mentioned to the patients. And from the literature, I think there's some center using the AI program to predict the soft tissue simulations after surgery, and they got around 0.1 to 0.2, so they got less. They got more accuracy over the AI simulation. So I think it is another direction we might we can focus on later on. And for the patient's calculations, because I would like the patients to be more statistic significance. So I use the sample size calculation, but I will check on it more if there's no retrospective study is not using this.
Thank you. And the final encouragement is we saw that your prediction has no difference on upper lip between two groups. Maybe in the future you can do the simulation to the CLAP patients and the similar facial profile of non-CLAP patient to see the upper lip difference, because after CLAP surgery, the upper lip has scar. Maybe the soft tissue change might have different from those from normal class 3 patients. Thank you a lot, and a very good presentation.
Thank you, Dr. Chang.
Thank you. Dr. Yao, could you have some comments or question?
Just one small question about because I saw your study design, the T2 is after 9 months or
Yes.
more than 9 months post-operative. Would you, because sometimes we set posterior bite in the surgical occlusion, and do you consider the counterclockwise occlusal plane change could be due to orthodontic factor, not surgical factor? Thank you.
Thank you very much. And this is an important question. And actually, all the surgical, all the skeletal movement and the skeletal changes we use are pre and finished data. But the occlusal, the occlusal plane, the maxillary occlusal plane data, we use a surgical achieved occlusal plane. It means that actually we measured this measurement right after surgery. So we actually use a pre-operative and post-operative less than 1 month to reduce the effect of the relapse.
Okay, thank you. No further questions.
So is there any further question or comments? If not, we thank Dr. Carol Chen. Thank you very much. And thank you everyone to join this meeting, and hope to see you next week. And we close the meeting here. Thank you.
Thank you.